Morning, everybody. Thanks for joining us this morning. So this is a webinar, a little bit different to what we've done before. So rather than have a guest speaker going through a particular subject or looking at a particular product, we've assembled a panel. So we've got a few questions to go through and answer. There's some really interesting content that's going to come through the session today. As always, if everyone could remain muted so that everyone can hear properly, and then we will go through the session. It should be around 45 minutes long, and let me introduce you to the speakers. So we've got Bridget Gaynord from Cambridgeshire. So let's introduce her first.
Okay, good morning, everybody. As Harvey said, I'm Bridget Gaynord. I'm an occupational therapist. I've got about 30 years experience working in the community. I'm also the clinical advisor to Cambridgeshire and Peterborough Integrated Community Equipment Service. And at present, I'm chair of the Eastern region of the National Association of Equipment Providers. Very good.
Thanks, Bridget. We've also got here Mel Sturman from Norfolk. Hello, Mel.
Good morning, everyone. Hi, Harvey. I'm Melanie Sturman, moving and handling lead for Norfolk County Council, slightly integrated post. We work across NHS and social care. Been in post 17 years nearly, and I was co-author of Handling of People 6th edition, and last year released a national back exchange publication on dementia care and moving and handling.
Very good. Thanks, Mel. And we've also got Rosemarie Scrutton from Hertfordshire. Hello, Rosemarie.
Morning, Harvey. Morning, everyone. I'm Rosemarie Scrutton, nurse by background, but Hertfordshire County Council's moving and handling advisor. And I've also been in post, picture Mel, 18 years.
Very good. So lots of experience, lots of knowledge between all three of you. Let's crack straight into some questions. So the first one we've got here is explaining the compatibility of postural positioning, sleep systems for postural positioning and pressure relief. So compatibility with those, and along with the Vendlet turning system and other bed mobility systems. So go for it, Mel. You've got a bit of experience in terms of in-bed positioning systems.
Meeting. I've used the Lateral systems with the Vendlet, and they've worked really well with supporting I would say low end postural care. We were having a sort of discussion about people with severe contractures and scoliosis offline. I've used them really well with people with dementia care. And obviously, as I said, I was really promoting about postural care and the older person, because I think we were saying that, children have really good sleep systems, but obviously often the adults forgot them. I'll hand over to Bridget and Rosemarie, because I think you've got more experience about using other products with the Vendlet, whereas obviously I've just stuck with that one. Okay.
I'll defer to Rosemarie. For those of you who don't know, in Cambridgeshire, we do have quite a problem funding sleep systems for adults, as they're not currently funded through the ISIS contract. So I think Rosemary's the best person to pick this one up.
My experience is that we tend to go with the Lateral, I've usually pronounced it wrong, so system, because again, we had a discussion before. And quite often with scoliosis and kyphosis, they're at the stage whereby it's medical intervention. So whether you go for a firm or a soft support, you won't actually prevent the condition, and you certainly won't reverse it. So it's about, I think, more often than not at this stage, it would be about pain relief, comfort, and managing where you are at the moment. You'll never stop the progression, but you may be able to slow it down. So, and it's on an individual basis, because what works for one doesn't work for another. We're very fortunate that we do have a joint funded store, so we could argue 50-50 that it's a medical need, but it's also a social need. So that's what we would be looking at predominantly in the community.
That's really interesting. So I'm not clinical, I need to make that clear. So, but from a product perspective, if we're talking about compatibility with the Vendlet, bracketed systems that are fitted down to a sheet, because the Vendlet sheet moves, that's part of the functionality, it's really difficult to integrate systems with where there's blocks fitted to the sheet. That's really difficult to work alongside with the Vendlet. And so something like the Lialet or Leisurelet, or whichever way you pronounce it, I know it's tricky. There's 6 cushions in there that you can choose between, and that just sits on top of the bed. It's not fixed, but it can be used for providing a high level of support there. If somebody needs fixing a particular position, then you are going to need something more bracketed. We had some interesting conversations offline about when you would and wouldn't use bracketed systems. Has anybody got any comments on that from our previous conversation?
I think I raised the point that the few that we've purchased, we do find that adults who are coming to sleep systems as a new intervention in their life find it very hard to tolerate bracketed systems, whatever their postural support needs. And as the key is to get a product in that's accepted. The softer systems comprised of pillows are more flexible and much simpler for the carers, whether they're family or formal carers, to use in a domestic environment. Children who are still growing and have requirements for their skeleton to grow equally and deformity not to build in as they grow are placed in bracketed, much more rigid systems very young, and become used to that and tolerate it much more. But it's quite hard for adults to be placed in those systems as something new.
Very good. Okay. So like you were saying earlier, it's not so much about stopping the system, stopping the curvature or the contracture or whatever. It's slowing it down and making it comfortable.
Yeah, it's more about, for an adult, just to sort of help you out a bit, it's more about with an adult supporting them in a safe position, but it's also about pain management. And also, even with the Lialet system, that I have actually managed to prevent contractures getting worse. And obviously those adults that are presenting to me with very, very severe contractions, we've worked really well with the system.
Good. Okay. I think we've answered that one fairly thoroughly. Next question then. When we need a piece of equipment that meets both health and social care needs, what's the best way of approaching funding for that one? I think, Bridget, this might be good to start with you on this one.
Okay, I'm in a very privileged position because in Cambridgeshire and Peterborough, the health and social care budgets are fairly well combined. They do still sit separately within the pool budget, but the criteria for everything from a raised toilet seat through to a hospital bed has been written from a combined health and social care perspective. So staff are able to order according to the criteria, but without having to make reference to the underpinning budgetary funding. What I would say is be really clear. We do have some items of equipment, special orders and issues like that, where it's not so clear. When you're presenting your justification, it's useful to be really clear and use the language of the organisation that you're approaching for funding. So if you're approaching health for funding, you need to use language with health outcomes to justify that equipment. And if you're approaching social care funding streams, you need to look at the goals and outcomes of social care and use that language and those outcomes to justify your equipment.
That's very good. Have you got anything to add there, Mel or Rosemarie?
I would just totally agree. We are fortunate. We have a joint funded equipment store as well. So, and it is about getting the right target on the paperwork so that then the justification is quite clear as to why you need that and what the specific needs are of the individual. And also, it's also worth mentioning that if it often can reduce carer input. I know the actual equipment service won't see any sort of savings, but certainly the service will as a whole. And at the end of the day, the budget is all one big budget. So any savings would be welcome.
Yeah, and I'm in agreement with Rosemarie and Bridget. Often what we do is, my role is I work quite closely with NHS colleagues, so they may well be going in because there's a health need, but there's also a social care commissions package. So actually, you know, in support of what Rosemarie and the Bridget's work, very much into about single assist. So often we'll look at what is that equipment, you know, the justification for needing a ventilator, justification for needing, I don't know, totos or different systems. And often we might split the funding, particularly if there is some pressure care element in that. So often they're 50-50, and certainly with my plus size bariatric patients, definitely we split the funding, because it's a whole, that it's looking at that, the whole holistic patient. And we know with obesity that it generates the comorbidities, which are health as well as social.
Good. Okay. Thanks for that. So another question here. This is a very, very detailed question, very specific and very complex. So we'll try and cover the principles as well as the govern it, as well as the actual specific case. So I have a client with spina bifida. She has double scoliosis and had to be hospitalized in mid 2016 for an ungradable sacral sore. She purchased a wheelchair in 2016, which is now unsuitable for her needs due to weight loss and altered posture. As a result of her scoliosis and weight loss, she leans heavily to her right-hand side in sitting. I'm yet to assess her positioning in bed. I would like some ideas as to how to best support her posture in lying, as she cannot lie flat. She has a dynamic air mattress and a product called an EcoMove, which, if anybody doesn't know, is a lateral tilt system. However, she cannot use the EcoMove as she cannot lie flat, and it triggers an alarm on the system, so she has stopped using it. She has developed another grade 3 sacral sore, and I want to make sure her posture is as well supported as possible throughout the day and night. I'm trying to encourage her to consider using some static seating in conjunction with a different wheelchair. So who's best to start off on that one? Mel, is that?
Yeah, I'll start, because I've got a similar client at the moment. What we were having sort of discussions offline is about looking at sort of compatibility of equipment. Remove the dynamic, remove the EcoMove, and look at one product. I'm happy if whoever asked the question, if you want to call, email Felgains, and then they can forward your email to me and I can send you the product. But I've used the Comfort Turn mattress, which is it's a dynamic mattress you can get, and it's also got the lateral turning mechanism as well. They are compatible with most beds. I've used them in conjunction with the ventilator system you're seeing behind you as well. What it will do is it deflates on one side and it inflates on the other side, and you can use it from a movement and handling perspective, but you can also use it as a tissue viability perspective as well. Now, you do need to do a risk assessment about entrapment, because obviously what I now base mine on our bed rail risk assessment, looking at an adult of around 1.5 meters, because as a mattress deflates on one side, we have had one incident with a very frail adult of them lying on their own at night with the turning cycle too long, and they obviously developed a problem with their arm. So you do need to look at those. With return, with a scoliosis patient, I have successfully used the Lateral roll, so it molds in really well. We've removed the pillow, we actually were able to put the lingerette roll as a pillow and mould it into her back, so it sort of formed the shape of the patient. In terms of whether you can use it in Fowler position, semi-recumbent, whatever language you guys use, yes you can, but obviously just be sort of mindful about the risk of patient falling out of bed if you're doing a turn in semi-lying. Okay.
Good. Anything else? Bridget, did you have something on that?
I think Mel's covered the case very well. I think this case illustrates the need to be very clear about what the outcomes and goals of your assessment and equipment provision are around. And is the goal primarily around managing her pressure care? Is it around managing her pain and comfort at night? Is it around turning her for the ease of the carers? Is the lateral offloading part of the pressure management? And I think once you've looked at what you're trying to achieve and prioritize those, it helps you decide what equipment to trial. I would also always say that in a case this complex, it's got to be multidisciplinary. Whether you're an OT or a nurse or a tissue viability, you're going to need each other. You need to talk to each other and the person herself to work out what the priorities are and what the risks are, and then balance those up.
Very good. Rosemarie?
Yeah, I would just add to that as well, that not to expect that the first time visit you'll solve all the problems. You know, it will be an ongoing thing that, so the expectation may be from carers, well, you know, solve it all in one hit, but that clearly never works. It's especially with cases like this, because what might work or might not work, may work or may not work. So you have to trial these things, but gathering all your information, gathering all your evidence to then make the best assessment as to, right, I think this is possibly the best way forward, and use that as your baseline.
Very good. Just on that specific mattress that you mentioned, obviously the lateral tilting systems like the Toto, the Ecomove and that sort of thing, they don't recommend, and like this, the Ecomove, it alarms if you go too high. What's the how does that work with the turning mattress? Is that a similar situation?
Not from my experience. I've used them mainly sort of for plus size individuals who definitely cannot tolerate lying flat. And I haven't had a problem. What we do is we just sort of put them into the lowest raised position that they can tolerate, and then obviously just make sure that the turning cycle, that the actual angle of the turn isn't too much. I think at the most they're usually around sort of 40-degree angle, but we'll just do a very sort of quick turning cycle. So it may be something like 20 minutes going from right side across to the left side, that kind of thing. So it eliminates this risk as much as possible. But like we said, didn't we, Rosemarie and Bridget, there is always going to be a risk, and you just obviously have to build that in your assessment. And obviously what we may consider and advise is the use of bed rails, subject to obviously your bed rail policy and assessment.
Very good. Okay. Anything else to add on that, or should we move on to the next question? I think we'll move on. So next one is, how is it best to support patients in the community while they're recovering from COVID or have been diagnosed with a long COVID? Bridget, you had an interesting point on that in terms of the fact it's no different from any other.
Yeah, I mean, the feeling in our area is that while we may see increased numbers of people presenting, these are no different to people who have come out of intensive care after long periods. They're experiencing the same fatigue, the same neurological impairments, the same psychological consequences that many people coming out of stays in intensive care have always done. There will be increased numbers. There are pathways being developed to support them because of that. But in terms of equipment provision, I see them as no different to anybody else. And if they have a shorter term deconditioning experience following COVID, then they're equipment, mobility aids, toileting aids, furniture raisers, that sort of thing, that anybody else who's undergone seasonal flu or chest infections would be entitled to. If they're suffering from forms of longer COVID, then again, they would be treated, and the same criteria would apply as anybody with a long-term condition that's leading to fatigue, restriction of movement, limited function, and the same criteria will apply, and we'll be providing equipment in the same way.
Good. Okay. Rosemarie, from a nursing perspective, what's your comments on that, and particularly from your experience in Hertfordshire at the moment?
Nursing, I haven't done nursing for a long time, but from Hertfordshire, we've got the 2 wraparound units that were opened to take quick discharges from our 2 acute trusts on either side of the county, and they have wraparound therapy there. So they don't have to just come from acute. They could be perhaps in a nursing home, perhaps in their own home, so that they can get that wraparound service. They would be moved into the 2 units, and hopefully their recovery would be much speedier, because therapy services in the community have been completely depleted with COVID. They've all been moved into the acute trusts, so they wouldn't get anything at the moment. So at least if they're in those 2 units, they would be able to access better services in the short term. But then that makes their recovery hopefully quicker, and they can get home quicker. So.
Very good. Anything on that, Mel?
I was just saying from my own experience of having sort of nursed people back or support people back from either short-term or long-term COVID, the challenges, in agreement with Rosemarie, have been about accessing health support with community physio input. Again, we've provided equipment and support as we would any other individual.
Yep. Okay, good. I think that covers the dreaded C word. Let's move on. So tilting and turning systems. So tilting systems like the ECMO that we talked about, the Toto, the comfy tilt's another one. So lateral tilting system, automatic systems, and then a turning system like the Vendlet, or the manual versions, the 4-way in situ slide sheets. From a manual handling perspective, Rosemarie, tell us when you would, that's often confused from my experience, the difference between those 2. Explain when you've used one of those systems and when you've used the other, and the difference, if that makes sense.
Sometimes it could be down to the individual that really can't tolerate being on a dynamic mattress of any sort. And also, again, as Mel has said about bed rails. So if they have capacity and are saying, I clearly don't want bed rails, but they're actually living independently, and you've got this tilt facility, what are the risks? You have to balance that up against carers that are there anyway, because they can't do anything for themselves. So it's an individual assessment, really. I can't say clearly one way or the other which way you would go. It would depend on the individual situation. But clearly with the 4-way system, if you've got a manual hoist, if space is an option, you may need to look at alternatives. But if you've got a ceiling track hoisting, you can use that instead. So it's always looking at the whole picture first. It's not easy to just say boom, 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 absolutely. You would go for one thing over another. But with the Wendylet system, that itself doesn't add any value to pressure relief in terms of offloading. So that's what you would need to look at. But you can use them on dynamic mattresses, obviously. So it's hard to say categorically.
Yeah. That's
a politician.
That's fair enough. There's clear differences from my perspective. Again, I'm not clinical, so I'll be reliant on what you 3 have got to say. But from my perspective, there's clear differences between an automatic tilting system which is purely therefore a pressure relief to offload those pressure points as it tilts. And then something like the Venlet, which is for predominantly for your moving and handling needs. So it brings a service user towards you, it will turn them right to their side for inserting slings for personal care, for repositioning schedules and things like that. It will move them back up the bed if they're slid down, that sort of thing. So is there also a moving and handling need that's being solved by a lateral tilting system as well? Reason for my question. Sorry.
It depends really what you're wanting the product for. I mean, how I got involved with lateral turning systems actually, gosh, many years ago, was actually a plus size individual. There we had quite a few men that were fairly independent with bed mobility, but they were struggling because of the adipose tissue and their natural build, bringing their arm across the chest. So actually that's when we started to introduce the lateral turning devices, so that it enabled them to be independent, and we weren't then needing to find 4 carers in lovely rural Norfolk to support the care. What we have found is obviously some compatibility issues. I try and look at providing 1 item rather than 3 items. So we've had people that wanted a Toto and then a dynamic mattress and then the Wendylet, and it's like, well, no, too much. We actually have made on our equipment prescription criteria that we wouldn't recommend an in-bed positioning system such as the Wendylet system or the ETAC system, because on top of a mattress, and on top of a Toto or the Ecomove. Because if you think about a product that's connected to a mattress, once that mattress is then turned on an Ecomove or a Toto, there is that risk of slipping. So you've got to look at, so what I have looked at is, okay, if it's just tissue viability, then I may go for an Ecomove, a Toto, or maybe just the lateral turning device. But if I'm really needing to do great big full hands-on movement and handling successfully, I've used a comfort turn, maybe mattress or a dynamic mattress or underneath the Vendylet, for example, to reduce the handling, so we can then manage both.
Yeah, that's good. Anything to add on that, Bridget?
I think when I work with our prescribers, because the word turning is used in both products, the Vendylet type products and the lateral tilt products, there is confusion. But I also think there is an area of overlap. So while products like the Vendylet are primarily about moving and handling and repositioning somebody, and the tilt are primarily about offloading for pressure relief, there is an area where, as Mel described, you can use a tilt piece of equipment like a Toto or an Ecomove to get somebody onto their side to help with moving and handling. And equally, both products can be used to reposition people, particularly for pain management. So you may be using a Toto or an Ecomove, a tilt device, to manage somebody's pain and spasm. Equally, you can use the Vendylet for that. So I think they overlap at that intersection, but they do have their very distinct differences.
Yeah. It's
and
really
just to add to that, Harvey, sorry, is that sometimes the certainly the base sheet can actually allow someone to actually do a bit of a hip shift themselves. So, you know, it's not necessarily all about doing it with them or to them. Sometimes that little shift might help them.
That's very interesting. That's very interesting feedback. In terms of the difference between the two, often with the standard clinical reasoning procedure, you have to go through your different costings first. So you move up through from the cheapest to the more expensive. So obviously the Vendylet being a very expensive piece of kit, people say, right, we're going to have to try a tilting system first. And it's sometimes bizarre because the tilting system, whilst it's brilliant for so many things, as you've described, if the if they're struggling with inserting a sling or something like that, it's not going to have that same outcome. So yeah, it's nice to get that. It's nice to get that cleared up.
But to also back up though, Harvey, I just want to say that there have been a couple of times where I have actually sort of put my neck on the line and actually bypassed trying other things, because from my little youth of 17 years of experience, I know that they're not going to work. So actually sometimes if you've got somebody that's palliative care, or you've got quite a volatile family situation, I've actually gone back to Northern Council and said, no, these are the reasons why I'm going straight onto the ventilator, and that's fine to do that as well. Yeah,
it's good to give people confidence to do that if they know from the start that something's not going to work for whatever reason. It's good to have that confidence to do that. Otherwise, it's just a waste of time and money, I suppose.
Yeah, I think it comes down to people knowing the outcome they want from provision of the equipment, and whether the pieces of equipment can provide that outcome. And if prescribers do understand the difference between the tilt functions and what those achieve and the turn functions, then they'll be able to justify going straight to the product that they need, rather than having to trial stuff that they know won't work.
Yeah, that's good. So knowledge of the product, knowledge of the need you're trying to meet is what you're saying, isn't it? Very good. Okay, now another interesting question. Single-handed care. When do we always need 2 carers for mobile hoisting? Rosemarie Scrutton, tell us about that one.
Absolutely not. It depends on the assessment of need. There's nothing in law that says you need 2 people for mobile hoisting whatsoever. And particularly if the person can actually operate the controls themselves, there's so much to take into consideration: environment, who's actually going to be doing the moving and handling, and where that person is going to end up, in terms of where are you hoisting them from and to, what is the end goal in that respect. But no, there's nothing anywhere that says it has to be 2 people. Quite often it probably will be, but that shouldn't be the go-to standard. Right, we must have 2 carers for me.
Very good. Okay. Mel?
I completely agree with Rosemarie, and I always sort of say to therapists about what exactly is that second person going to be doing. So, actually in terms of, we've changed from moving and handling to moving with dignity, do you need to have 2 people there? And I deal a lot with single parents and with children or young people, and we've actually looked at, for example, to enable that person to be hoisted independent from the floor with one. We've looked at changing from one manufacturer where you have quite a V-shape leg opening to one that's more of a square shape opening, so that creates that more space. We were talking offline about there are mobile hoists that are powered. So there's it's very confusing, EcoMove and EverMove. This one's called the EverMove, and it's fully powered. The wheels are powered, so you could challenge that. Actually, you could use that by one.
Yeah. Okay. What would the situations be where you do need 2 carers? What's the criteria, if you like, for when risk assessments would say actually yes, 2 people is needed?
You'd probably be looking at challenge behaviour or behaviour that challenges. Definitely consider the environment. I'm not going to sort of say be prescriptive, Harvey, because it's down to looking at the environment. Is there carpet issues, floor issues, space issues? You'd also be looking at the individual handler themselves, age, pregnancy, competence, etc. And obviously, as I say, the dynamics of the patient, the weight, their behaviours.
Yeah. So I quite often come across situations where I'm working with a prescriber to get a piece of equipment in, and from their professional opinion, the piece of equipment that we're talking about, often it's the vendor, because that's what I do. But they then go to a care agency and say, this is going to be a single care case, and they say, no, sorry, it always has to be two, and we're not going to take this case on because we don't do single-handed care. How do you navigate your way around that?
Go to another agency with a commissioning contract that actually states that, you know, what if the OT has assessed for X number of staff, then that's what they have to accept. But rather than presenting them with a fait accompli, it would be much easier to actually bring them along so that they can actually see what the situation is and they can get an understanding if they've not come across it before, so that you're actually getting them on board rather than sort of that, right, this is it, take it or leave it, because they probably will leave it and we can't afford to leave it. We don't have enough carers and care agencies at the moment. So it's much better to work with them and say, look, we're looking at this. Now we've got Microsoft Teams, we've got Zoom, we've got YouTube, all of those things. There are clips on there. So it gives them an idea, because as professionals, we sometimes forget that some of these people may not have come across this, and it might sound absolutely horrendous to them, and drop in the fact that, oh, we're going to do it with one person. Okay, so it's worth negotiating and having that conversation at the beginning to say, you're saying you can't provide 3-4 carers. We're looking to perhaps look at this piece of equipment and get their opinions first up. Then you might get a win-win. Not always, but that for me would be your starting point.
Yeah, that's
I totally agree, Rosemarie, because we expect care providers to be trained in absolutely all of the moving and handling equipment, and they're not trained in the ventilator and very complex pieces of equipment. Another thing that I've done is also look at, maybe we will have, say, 6 weeks as a double assist care package while everyone's learning about the patient and the equipment, with a view to, once we've actually stabilised the care package, we'd then reduce at that point as well.
That's good advice. Thanks, Mel. It often comes up about the insurance around 2 carers versus 1 carer. What's your experiences on that? Bridget, did you?
I know when our single-handed review team was set up, this was an issue they looked into at great depth, because it was a challenge that came back from nearly all the care agencies, was that it was a legal requirement to have 2 carers when using a mobile hoist. And of course, there's nothing in law that says it has to be 2. The law says you have to risk assess on an individual case-by-case basis, and sometimes it may require 3 staff to use a mobile hoist with somebody. So it's always based on risk assessment. The care agencies then fell back on, well, our insurance says that we have to have 2. And our colleagues in the single-handed care review team contacted the insurance companies that underwrite the insurance that care agencies take, and there is no requirement from them. They concur with the law that it's all about individual risk assessment, and that the care agencies should be working to the moving and handling plans written by the qualified staff.
That's really good advice. Thank you very much for that.
And also, when you say to them, Harvey, we've got people that hoist themselves. Many people self-hoist, you know, across the country, that successfully. So, and also, if you provide a living carer, you know, they often are doing it alone successfully as well. So it's making them more aware of that. Then gives them, I think for some of them it was a financial thing. They felt that they would lose money, but for me and for Bridget and Mel, it makes their workforce more flexible, because they can take on more care packages for us. You know, it's a win-win.
I think the issue of capacity within the care sector is a big one. And when we talk to our prescribers about promoting single-handed or moving and handling with dignity, one of the things that we emphasise more is that it creates capacity within the care field, less on cost and more on capacity, because that's what we're short of. That's what we're really short of.
Yeah, there's always going to be more unmet needs than there are carers to fulfil them. So.
And we've also yes, there is.
So I think we lost you for a
we've
second.
also
Sorry, carry on.
I think I'm back. No.
Yeah.
I think also it's about working with family carers. So it may be that we might have one provider, agency carer, working with a family carer. So obviously we've just updated our Moving with Dignity forms, which actually considers the involvement of the family carer, and then we can actually send that, because one of the challenges I get is who trains, who demonstrates to the family carer. So we've now got an updated document that we can print off, send it back to the care provider and say, look, as a clinician, this is what we've done. So there is no reason why you shouldn't be able to work with that family carer as well.
Very interesting. Did you have something, Rosemarie, on the kind of evidence in terms of accidents, if you like, in from double ups to single-handed care?
Oh no, historically it was always felt that care agencies felt that if there were two workers, then they were less likely to make a mistake and they wouldn't be sued. But the evidence is that people that do single-handed care are less likely to have human error in their working, because they are relying on themselves rather than assuming in the case of two people. So the evidence there suggests that single-handed is actually safer more often than not. Yeah,
very interesting. I guess one of the things which has come through very strongly in this whole session, regardless of the question, is we must be focused on the need that we're trying to meet rather than blanket protocol.
Can we say demonstration is the same as training?
Go for it, Bridget. Bridget, you're shaking your head there.
Okay, to me, particularly when it comes to moving and handling equipment, there is a massive difference between demonstration and training. Demonstration is where we show somebody, whether it's another clinician or it's a family member or the service user, the product, to see their engagement with it, to make them aware of the features and the functions of the equipment. Training is where you have a set of specific learning outcomes that you need a specific individual to achieve in order to use that equipment or that procedure safely. I don't know how the other two feel.
We do a demonstration with the person. We get them to do it. That's what our clinicians do. We'll do the demonstration, and then we get them, the family members, to actually demonstrate back, or the carers, whoever, and then that's documented that they on that day at that particular time they were competent to use the equipment as demonstrated by the OT or therapist.
That's really interesting. Go for it, Mel.
We've, as I say, we've just literally updated our Moving with Dignity risk assessment, and then, so we had 3 forms. We've now put them all on one, and we've actually used the word demonstration. I'm a trainer because I've done my training qualifications, and we really wanted to separate that from the occupational therapist, because we do get asked, well, can't they train us? No, they can demonstrate. So we actually have a comment, that a box that will say, has the therapist done the demonstration? Have you observed the user of the equipment, using the equipment? And then we sign off, is the person competent or not competent? And we basically give our OTs some very clear guidelines. Are they, about dexterity, mental capacity? Are they following some simple safe move and handling principles?
Good. Mel, the form that you use with the care agencies that you've made, is that something that is just is that something that you can share, or is that?
I will be when it goes live on Monday next week, but it's just something that we wanted as integral as part of the normal moving and handling plan, but actually so we and we can obviously have the principal part, which said the competence. We have agreement from that informal family carer that they will all be there. I'm sure Rosemarie and Bridget have horror stories where individuals have said they're going to be there and then they're not, and then at least we're then covered insurance wise.
Yeah. Okay. So when that goes live, where do people find
I can share a good practice. I'm happy to share a PDF document to you guys at Felgains if you want to distribute it.
Ideal. That's really useful. Normally after these sessions, we send around sort of resources and things that have come into the session. So I guess as and when it goes live, we can send around a link on that. Very good. I think that is the end of the session. That's been very, very interesting for me personally, and hopefully for everybody else as well. There will be a recording available shortly. So we will thank you everyone for joining. Thanks for all the questions. Thank you, Bridget, Mel, and Rosemarie for all the input. It's been very, very useful. And we'll see everybody again soon.